the exit exam. So this is the first class, very first class. And for diabetes, please note that the classes will be held on every Monday between 3 p.m. to 4 p.m. And there are very prominent, or you can say leading personalities of diabetes who are being enrolled as teachers, who have agreed rather to take classes of the students, and they will be giving their lectures on the respective Mondays. So we will urge also the students and attendees and those who want to do this course that please attend all the classes, because we will be marking attendance of these classes, and those who remain absent for more than maybe 3 or 4 classes, probably they'll not be eligible for the exit exam. And I hope that the classes will be of too much benefit, and we can always have some discussion basically after the classes also, or you can put it in the chat box as it happens in the Zoom meetings. So thank you very much, Dr. Kamlesh Tiwari sir, and I'll be just introducing the subject today. So that would be the introduction to diabetes mellitus. And we all have been hearing about diabetes right from the undergraduate days, when we start reading about our pathology, and then basically the pharmacology, and obviously then medicine, which comes in, it tells you about the diabetes mellitus. So we all are aware, it is only that we should know something more than that, and we should be able to address the problem, because we all know that diabetes is a global epidemic. And India, as Dr. Jyotirmay Paul said, that is the world capital of the diabetes. So we are altogether more concerned with the Indian population. So let me just give me a moment. I will just share my slides and then we'll start. Sir, can you see the slides?
No, not now.
The slides are visible?
Yeah, it is visible now.
Okay, thank you very much. So the learning objectives for the introductory module on diabetes is basically to define the diabetes, and there have been changes in definition of diabetes, and off late the classification has also slightly changed, or you can say not changed, only there are additions to the diabetes classification. So we'll learn on later in the module to learn about some of the important milestones in the history of diabetes and its management, to understand the magnitude of the problem of diabetes and the role of primary care physician in tackling it, and to understand the basics of normal intermediary metabolism and its hormonal control, and to learn about the pathogenesis and pathophysiology of type 2 diabetes. So pathogenesis and pathophysiology we will take in the second class, and the today we'll just have the introductory module. So let's just see the case. So we start with the case. A 52-year-old man comes to you with blood glucose values of 198 milligram percent and 362 milligram percent in the fasting and the postprandial state respectively. And he's not known to have diabetes and was discovered to have these values during a routine health checkup. So this is a very common situation when the patient comes to the clinic for the first time, or they just get accidentally get their sugar checked and these kind of values. So what proportion of patients with diabetes are unaware that they have the condition, and what symptoms can alert one to the presence of diabetes, and how common are these symptoms? What are the complications of the diabetes can a patient have at the time of first diagnosis? So this is the situation. These questions come, that probably this patient was unaware about his condition. Was he having any cardinal symptoms? So, what are the common or cardinal symptoms of diabetes? Or sometimes the patient they present with the complications also, as it happens in type 1 diabetes, where people land with diabetic ketoacidosis. So, what are the complications of the diabetes? So let's see another case. We'll answer these questions later on in the module. So case study 2, in an 85-year-old man with diabetes of 42 years duration is evaluated, and you are pleased to find that he has absolutely no evidence of any chronic diabetes complications. Can an individual with diabetes enjoy a normal lifespan? Please note that the patient here is 85-year-old man and with a history of diabetes for 42 years duration. Or can diabetes complications be prevented totally, as must have happened in this patient? So, this is possible, and this is what we want with diabetes as on today, that even if somebody is suffering from diabetes, then his lifespan should not be compromised, and he should not suffer from any significant complications, whether it is microvascular complications or macrovascular complications, or other complications like infections or other things, which can jeopardize the health, or you can say the lifespan of this patient. So, another case study, a 65-year-old lady is evaluated for diabetes and its complication, and she has diabetes of 16 years duration. She is found to have fasting and postprandial glucose values of 108 and 146 milligram respectively, and HbA1c of 6.8. However, further evaluation reveals the presence of proteinuria and moderate non-proliferative diabetic retinopathy. So why should this patient with apparent good control diabetes develop complications? Whereas in the previous slide you have seen that an old man of 42 years duration was not suffering from any complication despite having a long duration of time. So what determines whether a patient develops diabetic complications or not? But this patient has considered that her diabetes control had been poor for the past 5 to 6 years and has only recently improved following initiation of insulin therapy. And she has other risk factors like uncontrolled hypertension. So these are the three cases which we have taken up just to stimulate you to the different questions which comes to our mind or in our different scenario, because I hope that everybody who has joined here is a practitioner or a postgraduate and has been dealing with the diabetes. So these are the case scenarios which comes to our mind or comes to our clinic every day, and they stimulate our mind as well. So what is diabetes? Let's see what is diabetes. The term diabetes describes a metabolic cum vascular syndrome. Please note, we know about the blood glucose. If you ask anybody, he will say that blood glucose levels of more than this and more than that is diabetes. Yes, it is, but definition of diabetes is it describes a metabolic cum vascular syndrome of multiple etiology characterized by chronic hyperglycemia with disturbances of carbohydrate, fat, and protein metabolism resulting from the defects in insulin secretion, insulin action, or both, leading to changes in both small blood vessels, that is microangiopathy, and the large blood vessels, that is macroangiopathy. So it's not only the glucose, it is the intermediary metabolism which affects the carbohydrate, fat, and protein metabolism, and thereby leading to the side effects of diabetes. Obviously, the blood glucose values are important, and when you define diabetes, then fasting blood glucose values of more than 126, that is fasting after minimum of 8 hours is required, fasting is required, or the postprandial blood glucose of more than 200, that is 2 hours after the last meal, regular meal which the patient is taken, then, and if the HbA1c is more than 6.5, then you label the patient as diabetic. Or if anybody who is having classical symptoms of diabetes with a casual plasma glucose of more than 200, then also he is labeled a diabetic. This is for a normal person. The definition for gestational diabetes mellitus is different, and we will have a separate class on gestational diabetes mellitus next time. So the detailed diabetes definition of diabetes will come later on, but let's see the historical background in diabetes. So what are the milestones in diabetes? It's not a new disease. It is only that the cases have multiplied like anything, exponential rise have taken place. But there have been reports as long as back as 3005 years ago, where the first report on diabetes was described in the Egyptian literature by Egyptian papyrus, and it's probably the oldest preserved medical document, which there have been 110 pages scroll containing 700 magical formulas and folk remedies, and it's in hieratic script that is similar to hieroglyphics, and it mentions polyuria. And this document was discovered in 1872. That means almost 150 years back. But it was Areatus in 2nd century AD. He was the first person to use term diabetes. We all know that the Indian history has been very rich as far as the science or even the medical science is concerned. And we know that our Ayurveda was very strong. And first report on diabetes in India has been postulated between 2nd to 5th century AD, when Charaka and Sushruta, they have they have described conditions like diabetes, and they have too much so for that extent that they have differentiated between diabetes mellitus from diabetes insipidus, and they recognize two type of diabetes, that is krisha, with that means lean diabetic, that is type 1 diabetes, and sthula means obese, so obese diabetic is type 2 diabetes. And they also mentioned, after the observation that diabetes runs in families, and they described polyuria and glycosuria, that is sweet urine or honey like urine. And they describe basics of treatment for diabetes, that is physical activity, diet, and probably keeping low weight. And they noted that the lean diabetics were difficult to manage, and they have very short lifespan, and they died within a short period of time, or maybe when they were diagnosed for the first time. So our own ancient literature is very rich about the disease. And as the time passed on and the historical event, then the science made progresses, so was the medical science which made progress, and the pancreas took the center stage for diabetes. And in 1869, Paul Langerhans from Germany, who was a medical student only that time, discovered that the pancreas contains two system of cells. One set secretes a normal pancreatic juice, the function of other was unknown, and several years later, these cells are identified as the islets of Langerhans in his honor. And 20 years later, it was the Polish German physician Oskar Minowski and Joseph von Mering removed the pancreas from a healthy dog to find swarm of flies on the dog's urine. So they could induce diabetes in that dog when the pancreas was removed, confirming that there is something which is being secreted from or produced from the pancreas, or pancreas is vital to maintain the blood glucose levels. And on testing the urine, they found there was sugar in dog's urine. So in 1901, Eugene Opie mentions diabetes mellitus is caused by destruction of islets of Langerhans and occurs only when these bodies are in part or wholly destroyed. So in almost 20 years later, in 1920, Benting, who was an orthopedic surgeon and was employed as a lecturer in physiology at the University of Toronto, Canada, was asked to give lecture on the pancreas. And while preparing for the lecture, his interest in pancreatic physiology was kindled, and he thought of way to extract the pancreatic secretion that can reduce blood glucose without the pancreas getting destroyed by pancreatic enzymes by ligating the pancreatic duct, thereby causing atrophy of exocrine pancreas. So exocrine pancreas was removed, and only the endocrine pancreas was surviving in his experiment, and from that the extract was taken out, and you can see over here diabetes, ligate pancreatic ducts of dogs, keep dogs alive till acinine degenerate, leaving islets. Try to isolate the internal secretion of these to relieve glycosuria. And these are the actual words scribbled by Banting in November 1920. And he presented his idea to James MacLeod, who was professor of physiology at University of Toronto. And it was the lab of MacLeod basically where all the discovery of insulin was being done. And MacLeod was not impressed with the painting but agreed to offer him the use of disused old lab and the services of an assistant. And this assistant was Charles Best. And by a coin toss, medical student got the opportunity to work with him. And in their experiments, they induced diabetes in dogs by removing the pancreas and tried to see whether glycosuria could be suppressed by administering fluid isolated from the islets of Langerhans cells of other healthy dogs. And in 1 year later, almost 1 year later, the first positive results were observed. And you can see here the dog Marjorie, who was kept alive with pancreatic extract injection for 70 days. So this is how the discovery of insulin was being made. So iletin was the name given to the extract in the pure form with the technical guidance of MacLeod and the help of expert biochemist J.B. Collins. And in 1922, Leonard Thompson was the first documented person to receive the insulin injections. He was the first subject to receive the natural insulin. And in 1923, the Nobel Prize was given to Benting and MacLeod, and they were shared with their respective colleagues. So then there were landmarks in therapy of diabetes, basically, where in 1876, again almost 150 years back, hypoglycemic effect of salicylate was noted. In 1921, discovery of insulin was made, as we have seen. 22, it was first used. In 26, insulin crystallization techniques were introduced. And in 1926, the first biogunide derivative was synthesized, and we are still using metformin as one of the successor biogunide. And before that, penformin was there, which was later withdrawn for its side effects. 1930, hypoglycemic effect of sulfonamides was discovered, and in 1942, prototype sulfonylurea was synthesized. And in 1946, NPH insulin was developed. NPH we are still using today, and you can see here that it is almost 80 years old insulin, which still is being used, although the purification processes have improved over the decades and NPH has become more purified for its use. In 1955, the first sulfonylurea carbutamide introduced in clinical practice, followed by tolbutamide, which again is no longer being used because of the better ones available in last 4 decades. In 1956, lente insulin was introduced. In 1957, introduction of the first biogunide for clinical use, that is penformin, was there, and in 1963, first premix insulin was introduced. Continuing with that, there was a continuous evolution of the therapy because the number of patients of diabetes were also increasing constantly. And in 1978, subcutaneous infusion pump was introduced in England, and in 1982 it was recombinant human insulin, which was approved by US FDA, and in 1995 the first alpha glucosidase inhibitors, that is the acarbose, was approved by US FDA for treatment of diabetes. 1996, first rapid acting insulin analog introduced, and 1997, the first thiazolidine introduced. The first long acting insulin analog was approved in 2003, first long acting. So that was glargine. And 2005, the first GLP-1 receptor agonist was introduced. And then 2006, DPP4 gliptins, which we are using day in day out these days, were introduced, and vildagliptin and sitagliptin came into use. And in 2013, another landmark therapy, that is the SGLT2 inhibitors, were introduced. And then there were modifications in the existing drugs, pharmacokinetic modification, where the first long-acting GLP-1 was introduced in 2014, which could be used once in a week. And then 2019, the first oral GLP, that is the semaglutide, was approved by US FDA. So this was the evaluation basically, if you see the historical aspect. Coming to another aspect of is the magnitude of the problem, that is especially type 2 diabetes. We will take type 1 diabetes later on, where we'll keep a separate class on type 1 diabetes, or maybe diabetes in young, and magnitude of the problem. If we see for type 2 diabetes, then it is the leading cause of end stage renal disease, ESRD, globally, leading cause of non-traumatic lower limb amputation, one of the leading. And believe me, the lower limb amputation we will see in later in our classes, but it is such a common problem globally that every few seconds there is an amputation because of diabetes. One of the leading causes of preventable blindness because of the retinopathy and the complicated cataract and other eye problems which it causes, along with the eye neuropathy. Then major risk factor for coronary artery disease and cerebrovascular disease, which is the major cause of mortality in diabetics and otherwise in general population also. So if you see the worldwide data, then more than 537 million adults suffered from diabetes, and this number is likely to go up to 784 million by 2045. And this is data is as per the IDF Atlas, that is the International Diabetes Federation, which keeps on releasing the data time and again. And if you see some of the data from India, then diabetes complications in India, uh, you can see that coronary artery disease is 21.4%. If you see the peripheral vascular disease, then it is 6.3%. Retinopathy is 17.6%. Nephropathy is 2.2%. And that is only microalbuminuria. And nephropathy is, neuropathy is around 26%. So if you see in millions, basically you can see the patient with the diabetes complications. So you can see the numbers were basically bifurcated over in millions also. If you see the epidemiology of diabetes, basically, then the salient features are that type 2 diabetes comprises almost 85 to 95% cases of all cases of diabetes, and rest of them being but the cause is either type 1 diabetes or secondary diabetes, or maybe the gestational diabetes. So 80, almost 85%. So major chunk is type 2 diabetes. And there has been an explosive increase in prevalence of type 2 diabetes in developing countries, and there has been a steady increase in prevalence of type 2 diabetes in developed countries. Type 1 diabetes also increasingly is increasing steadily in developed countries, but not a major problem yet in developing countries, because it is supposed to be an autoimmune disease. And we all know that autoimmune diseases, they have been rising in the developed countries, where the rate of infections have gone down, but the autoimmune diseases have gone up. But in India also, type 1 diabetes, the numbers, because of the large population, have gone up. And other forms of diabetes, they are rare, where you can have the genetic diabetes like the MODY, or maybe the secondary diabetes because of the pancreatitis or hormonal disorders or drugs. So that we will discuss in the later classes when we will see the classification of diabetes. So type 2 diabetes in developed countries is a disease of middle age and old age, and it is associated with overweight and obesity. And the worrying trend is there is an increase in type 2 diabetes in children also. So it's not uncommon that you will find somebody who is 15 years, 17 years, or 20 years, or 25 years to be suffering from type 2 diabetes. Because, as per the earlier notion that somebody who was very young should have or can have only type 1 diabetes, does not hold true these days, because of rapid rise in obesity in school children and young teens and adolescents. The type 2 diabetes incidence has gone up in younger population also. If you talk about type 2 diabetes in India, it occurred a decade earlier than in the West. That's the worst part. We are suffering with large numbers of diabetes. India ranks second as of now after China in numbers from for as far as the diabetes incidence is concerned. But the problem is that it starts a decade earlier. Suppose if it start on an average of 40 years in the Western population, then in India it is almost 10 years earlier. It occurs even in non-obese individuals also, because we are lean fat phenotype. That means the percentage of fat of Indians and Southeast Asians is much higher as compared to the muscle and the bone mass. Therefore, the person may appear non obese, but because of high fat percentage, the insulin resistance may be higher, and type 2 diabetes can happen in apparently non obese Indians. It is seen in children also, although less commonly than in the West, and Indians are more prone to develop cardiovascular disease, and that is the major problem. And we all know that the leading cause of mortality in Indians these days is the cardiovascular disease, whether it affects the heart or the peripheral arterial system or the cerebral circulation or maybe the renal circulation. There have been some studies which suggest that probably Indians, they have slightly lower risk of microvascular disease as compared to the Western population, but that will not hold true if the glycemic control is not good in Indians. So, if you see the top five countries with diabetes burden wise, then you can see that India, China is on the top with 140 million. India is around 74 million. Pakistan 32.9 million. United States 32 million. And Indonesia is 19.4 million. And this again is the data is taken from International Diabetes Federation, IDF. So we are second, but we are catching up fast with China, and that we may become the diabetes capital of the world, leaving China also behind us. So that's not the good part. So if you see the prevalence wise, absolute numbers is a different thing, but prevalence is basically how many people per 100 or percentage. Then obviously Pakistan is at top. French Polynesia, Kuwait, Northern Mariana Islands, New Caledonia, and Nauru Islands, they, uh, if you see the prevalence wise, percentage wise, then they are much ahead of us. Rising prevalence of diabetes in India. You can see the rural and the urban areas over here. So the green one is with the lowest, and then followed by the yellow, then orange, and then red, where red is 12% and above. And you can see here that in the southern parts is, you can say, Tamil Nadu, Chennai, with a prevalence of 5.6%. Hyderabad is 4.1%. Bengaluru is 2.3. Mumbai is 2.1. So that way, the southern part had more prevalence of. And just see, that was the old data, 1960, and now if you see this data, how it has changed. And you can see the 2014 data, and you will see that the whole map of India has become colorful. And these are bad colors basically, because they denote the rising prevalence of diabetes across India. And you see right from Kashmir, which stand at 4%, to s- to maybe Rajasthan, which is shown in green, the MP, which is shown in green, which has lower percentage. But as you move down south again, then Maharashtra, then Karnataka, then Tamil Nadu, and Kerala, then you will see that the prevalence of diabetes is increasing as you move down south, with Kerala having probably the highest uh, a prevalence. Kochi is showing 20%, but surprisingly, Jaipur, from which the place which I belong to, is also showing very high prevalence of almost 20%. If you see the rural India, initially diabetes was thought to be the disease of affluent people and those who were obese, but unfortunately, the disease has caught up in a rural part of India also. And you will see that how the rural picture on the left hand side shows increase in diabetes prevalence. So this ICMR INDIAB study, which is the largest study of diabetes in India, which was conducted under the auspices of ICMR, it studied every state in India using a systematic random sampling method to obtain a representative sample of the country. And total sample was 1,20,000, which is a huge number. And the study, when it completed, and in almost 15 states and union territories, it showed the prevalence in different states and union territories over there. 14 states and one union territory of India was studied. And you can see here, right from starting on the left hand side from Bihar, which showed the prevalence of 4.3%, followed by Meghalaya, then Manipur, then Arunachal. So all eastern states, then Jharkhand, then Assam, the prevalence kept on increasing. And as you came down to the western part of the country, that is Gujarat, the prevalence was 7%, Karnataka was 7.7, Andhra was 8, Maharashtra was 8.4, Punjab was 10, Tamil Nadu was 10.4, and Chandigarh, which is a union territory, the prevalence was 13.6%. And this data was published in Lancet in 2017. So nearly 50% of people with diabetes in India are undiagnosed. This is another big problem, because if the disease can be diagnosed early, well within the time, then probably you can address the problem and stop its progression, or the complications which comes in with long standing diabetes. So almost 50% people were undiagnosed. Looking to the high prevalence and high complication rate and the mortality happening because of diabetes, there was a national program for prevention and control of cancer, diabetes, cardiovascular disease, and stroke, that is NPCDCS, which was an initiative of Ministry of Health and Family Welfare, Government of India, which was launched with the objective of risk reduction for prevention of non-communicable diseases and early diagnosis and management of these non-communicable diseases, which are on continuous rise, including cancer, diabetes, CVD, and stroke. And The NCD clinics were set by at various district levels across the country under this program. And pilot phase was launched in 2008, and later on the program got the approval and was expanded to all over the country. And you can see here that it has covered almost all districts of all states, union territory in India by the 12th 5 year plan. And with the strategies to promote healthy lifestyle through massive health education and mass media efforts, universal screening of adults for five diseases, that is diabetes, hypertension, and the common cancers like the breast, cervical, and the oral cancer, and with setting up of NCD clinics at CHC and district level, and development of trained manpower and strengthening of tertiary care facilities for these diseases. So, when this program was launched and with such huge numbers spread across these rural and the urban areas of the country, the role of primary care physician becomes very important, and diabetes is too large a problem for government to tackle on its own. And we all know that we do not have sufficient trained specialists in India to deal with the burgeoning epidemic, and and therefore it becomes more important that every general practitioner be familiar with the basics of diabetes management. And in that endeavor only, this module has been, or this certificate course have again been started by ICP, so that we have more focus on the epidemic which is spreading from metro cities to smaller towns and even to villages. And in all these places, the primary care physician has a major role in identifying and managing diabetes and making prompt referral if any person with diabetes has any complications. So nearly 20% of adult patients in general medical OPD will have diabetes. So that is the importance. Every fifth patient coming to a practitioner will have diabetes. And talk about any specialty, somebody going for a surgery, somebody going for a cataract surgery, somebody going for a delivery, somebody going for a eye surgery, if they suffer from diabetes, then there is a role of internist, endocrinologist, diabetologist, primary care physician to address the problem. But more than half of these patients are unaware that they have the disorder. So, screening at every level has to be strengthened, and the primary care physician has unique opportunity to identify and treat these cases at the earliest possible stage. We all know that the status of diabetes awareness in India is blissful. There is high level of ignorance as far as knowing about the disease, as far as the management of disease is concerned in form of diet or maybe a treatment or regular checkups. And only around 43% of individuals have ever heard of diabetes, and 50% do not know that diabetes can lead to organ complications, and more than 80% do not know the risk factors for diabetes, and 50% do not know that diabetes can be prevented. The primary care physician has major role in educating his patients and their relatives about diabetes so that they seek detection and care early. If you see the status of diabetes control in India, because anybody who has been diagnosed with diabetes, you just cannot get rid of the disease or maybe completely cure him, but you can always control the diabetes, or you can achieve the glycemic targets in these patients. So if you just see the status of diabetes control in India, so it's a case of too little being done too late, and only around 20 to 30% of patients have HbA1c of less than 7%. No consensus on glycemic targets and guidelines among doctors, and management of lipids and blood pressure is suboptimal. More than 50% of patients are not informed or aware about their glycemic targets, and the situation can only be improved by training of the doctors, especially the physicians who treat most of the diabetes patients in this country. So physicians, they are ideally suited to provide a quality diabetes care to patient on account of acceptability, availability, and affordability. And it is imperative that these physicians, they should be trained in every aspect to tackle the diabetes scenario. So with that, I end my talk over here, and from next module, we will just start with the pathophysiology, and we will take the glucose metabolism from the next class, which will be held on next Monday, that is 17th of February at 3 p.m. So I end my talk over here, and I hand over to the organizers, that is the Indian College of Physicians. And if there are any queries or suggestions or questions, they can be put into the chat box so that we can take a reply.
Thank you, Dr. Punit. Thank you very much for this wonderful lecture on diabetes mellitus. Now, I will request the candidates to put question or suggestion or comment in the comment box, and we will try to solve those questions. Thank you very much. Thank you, Punit. Heads off.
Thank you, sir.
Thank
I
you.
don't think there are any questions, but I will urge all the attendees that please don't hesitate. It's an open forum, and
Yes.
any question or any suggestion are more than welcome. And as you raise the questions, we will raise the bar of discussion, and we are starting with the basics, and then we can stretch the discussion to any level. And I can assure you that we have designed the program under the leadership of API and ICP in such a way that it will be a very informative certificate course, and those who will attend all 20 classes will be at least ready to tackle each and every aspect of diabetes if they attend all the classes. Thank you very much. Thank you.
Thank you, sir.
Thank you, sir.